Hello, and welcome to the June 2024 issue of IGIE. My name is Phillip G., Section Editor for the Historical Considerations section of IGIE. In the world of endoscopy, sometimes the greatest ideas come from faraway lands. A promising young colorectal surgeon, practicing as a junior faculty in Japan, relishes the opportunity to take 2 years of sabbatical leave to the United States to bring something back to his academic department in Japan. It is not until he arrives in the United States that he realizes he possesses a unique and extraordinary skill: endoscopic submucosal dissection, or ESD, a procedure commonplace in Japan but rare in the United States. Realizing that he has essentially landed in the right place at the right time, he sets out on a mission to teach ESD to his American counterparts, and in doing so, finds his calling in medicine. Such is the story of Dr. Hiroyuki Aihara, who is our distinguished guest for the Historical Considerations section of IGIE. Dr. Aihara has established himself as one of the foremost ESD masters in the United States, whose passion and vision is in education, and whose goal is the universal adoption of ESD in the resection of large superficial neoplasia throughout the GI tract. Humble, soft-spoken, and technically gifted, he has taught his art to numerous physicians in the United States and established the first of its kind ESD fellowship in the U.S., providing a novel training pathway that did not previously exist. Dr. Aihara is currently an associate professor of medicine in the Division of Gastroenterology, Hepatology, and Endoscopy at Brigham and Women's Hospital, Harvard Medical School, where he also serves as the director for endoscopic tissue resection. It is a great pleasure to have you here, Dr. Aihara. Thank you so much for taking the time to provide this interview. It's such an honor and privilege. First of all, congratulations on your 1000th ESD. How does it feel to achieve such a significant milestone?
Thank you. So I'm very grateful to my division, especially to Dr. Christopher Thompson for giving me this great opportunity. And then I also thank the advanced endoscopy team at Brigham and Women's Hospital. I think I wouldn't have achieved this milestone without their support. My first ESD case was in 2015. So this was the first ESD case in the United States for me. And then the number 1000th ESD case was like 7.5 years later. It was on December 22nd in 2023. I think for the first few years, I just did about 30 to 40 ESD cases per year. But however, I think for the last few years, the ESD, I think it was become more recognized. The number has become more like exploded to 200 to 300 ESD cases per year.
That's truly impressive in terms of the volume that you have, and a testament to your skill. Or I guess, should I say, you've made it. Good job. So before we continue, tell me about the case. Did you pick this case knowing that it was going to be case number 1000?
No, actually, so I think, as you know, I keep the case log for ESD. So when I did the number 990 case, I told the endoscopy team that my number 1000 case will happen sometime within a month. So the team started to count down, but I didn't know which exact case would be the number 1000th case. So simply because sometimes, as you know, the ESD can be sometimes canceled because of the prep, or some cases can be converted to EMR. So actually, I ended up learning the day before that I would reach the number 1000 case. So the lesion was like 6 centimeter laterally spreading tumor in the rectum. And then the patient already had the EMR attempts, and then it was a recurrent lesion. And then the biopsy showed the at least intramucosal adenocarcinoma. So during the ESD, I encountered a lot of fibrosis from the previous EMR attempts, but I was able to use the traction technique to overcome that issue. And also after the resection, I used the endoscopic suturing to close the defect. So I think it was a very good case to showcase some modification that we have made to the ESD in the United States to the original Japanese technique of ESD.
Very nice. And, having made history now in the United States, let's kind of go back and talk about history, actually. So, first of all, tell us a little bit about your upbringing. What were you like as a kid? Tell me about your parents and about the Japanese education system that you grew up with.
Sure. So I was born in the Miyagi prefecture. So this is the northern part of Japan. And then I was raised in Saitama prefecture. It was close to the Tokyo. So basically my parents moved from the Miyagi prefecture. It was their hometown to the Saitama prefecture for my father's job. So at that time, my father was working as director of the research lab at the one of the pharmaceutical company in Japan. And then growing up, he always taught me how human body was amazing. And also he taught me how the medicines were used at the time to treat the patients and then recover from the diseases. He also frequently traveled overseas, such as like United States or Europe a lot of times. And he gave lectures and then attended a conference. He also brought me some small gifts and he showed me some pictures from the Europe or United States. And it motivated me a lot to go outside of Japan in the future if there's a chance. So he also told me to working outside of Japan, if I have a chance, and then to challenge my skill abroad. And then I think I was 6 years old when my maternal grandmother passed away from colon cancer. So she was only 65 years old at that time. And then I remember asking my father why the doctors at the hospital couldn't treat her. And then he told me that there's simply no way to give her any curative treatment. So I think she had a stage 4, that's metastatic colon cancer to the liver, and then she couldn't receive any type of curative treatment. So that was my initial motivation to enter medicine and then become a physician. And then I was raised in a traditional Japanese family. And meaning my mother was a housewife and she stayed at home and supported me as I grew up. And then the Japanese education system, as you may know, is very competitive at the time. So I had to enroll in a cram school to study to enter the high-level high schools. And then in the United States, I think you enter the medical school after completing the 4 years of undergrad college. But in Japan, it's a little different. So we entered medical school right after the high school. So I had to decide when I was the 16 to 17 years old to choose the medicine or other specialty. So I had an interest in pharmacology at that time because of my father. And then I was also initially interested in aerospace engineering. But my father actually told me that realistically, I was not likely to be able to become the leader in this field. And then I won't be able to venture out of the solar system because of the limitation in the technology. So primarily motivated by grandmother's death, I decided to go to the medical school at the time.
It's a very fascinating story and kind of showcases the differences in education between Japan and I guess the rest of the world as well in the United States. It always impresses me that you're able to decide when you're 16 or 17 years old what you're going to do with the rest of your life. I always find it extremely it's very impressive. We'll put it that way. So now within medicine, you were originally a colorectal surgeon. Tell me about your journey and how did you decide to become a colorectal surgeon?
Yeah. So let me talk about my student life at the medical school. So I entered the GC medical school in 1992, and then I was graduated from the medical school in 1998. So in Japan, it's the 6 years program for the medical school. And then after graduating, I stayed at the same GC medical school for my residency training. So the GC had a very special, unique training system. for the residents. So it was a 2 years program, but I spent like 12 months in internal medicine. And then afterwards, I had like 6 months of surgical residency program. And then it was followed by 3 months of the interventional radiology. And then finally, I did the 3 months of cardiac and general anesthesiology. So I was able to see like almost all of the medicine aspect of the medicine during the span of the 2 years residency program. And then during that time, I was, as I said, primarily interested in the GI cancer treatment because of my grandmother's death. But there's no such field as the clinical oncology in Japan at that time. So basically, all cancer patients were treated by GI surgeons. So basically, surgeons made some diagnosis, and then they complete the staging, and then perform the surgery. And then, if necessary, they did the chemo. So only the surgeon at that time could treat the cancer. So this was how I decided to become a surgeon rather than the gastroenterologist. So, so the reason for why I became a colorectal surgeon. So this was after the residency. I stayed at the JIKCHI Medical School for my surgery fellowship. So during that time, I had a surgical mentor. His name is Dr. Yutaka Kawamura. He really inspired me to specialize in colorectal surgery. So Dr. Kawamura, he was very unique at the JIKCHI Medical School because of his origin. So he came from a different medical school or institution. He was not very common in Japan at that time because Japanese academic divisions were somewhat exclusive. And then they mainly accepted the graduates from their own medical school. So it was very unusual to have somebody from the different medical school at our division. But Dr. Kawamura brought with him a different mindset and also the skill set, which left a very lasting impression on me. So he taught me the basic and also the advanced skills in open and the laparoscopic surgery. And then he taught me how to conduct the research in the surgery. And he also taught me the colonoscopy and polypectomy and EMR at that time. So I learned a lot of things from him. And then Dr. Kawamura gave me a life lesson that I always remember still now. So in general, there tends to be some kind of like comfort or satisfaction when we stay in the same position in the same institution throughout the career. So he taught me that when we stay in the same position, there tend to be no chance to improve our skills any further. So he really encouraged me to seek different environments throughout my life to challenge myself. And then it really motivated me to seek other areas to do the research in the future.
It's very interesting.
This is how I decided to become a colorectal surgeon.
It's very interesting. It's a great story. It's very inspirational as well. So, despite being a colorectal surgeon, eventually you switched over to the dark side. And you decided to pursue endoscopy, and then you became trained in ESD. How did you decide that you wanted to pursue endoscopy rather than traditional colorectal surgery, or even say laparoscopic surgery, or even let's say robotic surgery? You were arguably primed for those rather than endoscopy. So how did you wind up in endoscopy? Was there a specific mentor or specific set of circumstances that inspired you along the way?
So after my fellowship training, I worked as the colorectal surgeon for 6 to 7 years. And then at that time, I was primarily performing the open colorectal surgery. And then because at that time, the laparoscopic colectomy has just started to expand, adapted in Japan. As you know, the open colorectal surgery was developed in the early 20th century. And then most surgical techniques has already been established, I thought. So I felt that there's not so much room for the novel research on the surgical innovation at that time. So I think it was 2006 when I saw the ESD starting to expand in Japan. And then I really became interested in this new procedure. And then in those days, I was performing colorectal surgery for those benign polyps that either I or my colleagues couldn't remove with a conventional EMR. So at that time, my primary interests were in the minimally invasive cancer resection. But at the same time, I felt the laparoscopic or robotic surgery just less invasive in terms of the just the length of the skin incision. So I strongly felt that it would be better to push the envelope from not from the skin side, but from the intraluminal side in order to remove those early stage GI cancers that doesn't need any lymph nodes dissection.
Very nice, very nice. It's so funny to see you swing from one extreme to the other as you were practicing open colorectal surgery, and then you wind up in like the most minimally invasive thing possible with ESD. How did you become trained in ESD? So tell me about your mentors who trained you in ESD and the Japanese method of training.
Yeah, sure. So I think this was the biggest change in my career. So this was when I went to the GK University to see Professor Hisao Tajiri. It was in the same year, 2006. He was the chief of the gastroenterology and endoscopy division at the GK. And then I decided to see him because his division was very unique. So he hired talented surgeons and gastroenterologists from all over the Japan, and then put them in the same division to have a space to collaborate like between the surgery and gastroenterology. So he also sent several faculties from his division internationally to key endoscopy centers like in the United States and Europe to do the clinical training and the research. So from that standpoint, the GK appeared to fit me better than other institutions because of the collaboration between the surgeons and the gastroenterologists. And I thought there would be a potential opportunity for me to spend some time outside Japan. So I decided to join their faculty. So I joined their faculty in 2007. I didn't do any additional ESD fellowship at that time. So instead, my colleague who were already proficient in ESD trained me. The Japanese hospital system is very different from the American system. So in Japan, the advanced endoscopy fellows typically stay at the same institution and continue training while they are junior faculty. So it's not uncommon to see several attending level physicians involved in the same procedure to train their colleagues. So that was my pathway. So I was trained in ESD for a few years as an attending physician.
That's very interesting. And then I noticed that you also have a PhD. Tell us about your PhD. What was your PhD project?
Sure. So I received my PhD while I was at the GK University. So in the United States, I think you typically have to enter the graduate school and then spend probably about like 4 years to earn the PhD. But it's the same in Japan. But there's also another track called PhD clinical track. So we can basically continue our clinical practice and then also do the research to obtain the PhD. So my PhD project was on autofluorescence imaging. It was called AFI. At that time, the Olympus was the experimenting new imaging systems to complement the narrowband imaging, NBI. And then they developed two modalities. So one is the infrared imaging, IRI, and then AFI. So basically the autofluorescence imaging, so this is based on the interaction between the light and then the endogenous fluorophore, so like the collagen in the human body. So usually the collagen is present in the GI tract, in the mucosa and the submucosa in the GI tract. And then when the tissues are exposed to a specific short wavelength of the light, the collagen basically gets excited and leads to the emission, the longer wavelengths of the fluorescence light. So the autofluorescence from the normal or hyperplastic tissue is very different from the dysplastic tissue. And then the AFI can capture the difference in the intensity of the autofluorescence. So with the AFI, the dysplastic polyps in the colon can appear as a purple or magenta. And then the normal or hyperplastic tissue will appear green. But the differentiation between the dysplastic and non-dysplastic tissue or normal tissue, it's a little, as you can imagine, it's very like subjective because you need to tell the difference in the color. So at that time, I was wondering how to objectively compare the two colors. So I actually developed the software to quantify the color in the RGB and then evaluated over 100 corrector lesions to determine if there's these polyps are dysplastic or non-dysplastic polyp. So in doing so, we were able to establish the threshold for the differentiation between the dysplastic and the non-dysplastic polyps. So, and then we added some enhancement to the software afterwards, and then we were able to make it to do this in real time by connecting the computer to the endoscopy processor. So we would capture images and then analyze the color of the lesions and then differentiate between the dysplastic and non-dysplastic polyps. So interestingly, I believe this ended up becoming one of the first published papers on the real-time computer-aided diagnosis, the CADX, on the colorectal polyps. So this study was published in GIE in 2009.
It's almost like you were, how do you put this? It's like you were before your time, right? It's like you're publishing stuff on CADX before AI became high.
Right. So there's no way. So there's no AI. So this was the
it's like one of the first AI programs to be developed. It's so funny to hear that now in 2024. But you were doing well. You know, your career was going well. You got your PhD. You were making all sorts of novel software programs. So, you know, when you're comfortable like that, it takes great courage to move and much less to come all the way across the world to the United States. And I would imagine also comes at a significant cost to your family too. But what inspired you to leave all this behind in Japan and come to the United States? Like, were you planning to just kind of visit for a little bit, or were you planning to stay in the United States? Were you planning to return to Japan? Tell me about what happened.
Sure. So this was actually the turning point in my life. So as you know, I had already been interested in doing research and working outside Japan because of my father, and in order to gain the different perspectives on the management of the diseases. So when I completed my PhD in 2011, it was like 5 years after I became a faculty at the GK. At that time, Dr. Tajiri, he gave me a 2-year sabbatical leave starting in 2012. So, and then Dr. Tajiri, I remember he recommended that I spend 2 years in Boston with Dr. Christopher Thompson. And he strongly recommended Dr. Thompson because at that time our division was doing some research on the nodes, natural orifice, transluminal endoscopic surgery. So the nodes research at that time was very active both in Boston and Tokyo. But we did some research on the multitasking platform called EndoSamurai from Olympus. It had some like 2 arms. It allowed us to do some interluminal bimanual surgery interluminally. And also at the same time, Dr. Thompson's lab was collaborating with the Boston Scientific. And then Boston Scientific at that time developed a new robotic, not a robotic system. It's a new system called direct drive endoscopy system, DDES. So it looked very attractive for me in Japan, and I wanted to learn how Dr. Thompson's lab did some experiments and how his lab members did animal studies. So I met Dr. Thompson for the first time in Boston in 2011 before the DDW. So at that time, I met him and I asked him if I could spend 2 years in Boston to do the research. And then he agreed, and then he was very welcoming to spend the time with him. So that was how it started. So when I came to the United States, so I came with my family. So my wife already knew that I was hoping to spend time in the United States. So she was very supportive. And then also my wife and I also felt these 2 years would be very good for our twin daughters because it would help them develop the ability to speak English. And then this ability to speak English was very useful for their future career in Japan. So for all four of us came to the United States at the same time.
And then you stayed.
Yes.
And now you're considered one of the foremost ESD masters and pioneers in the United States. What happened? What led you to remain in the U.S. and become a U.S. master?
Yeah, so as you know, I was supposed to go back to Japan after 2 years sabbatical. So what I did during the 2 years time in Boston was so unfortunately, during these 2 years, the notes movement just faded because of the multiple factors. And then also the notes research declined as well, unfortunately. So I had to seek other research topics. So basically during these 2 years, I did some research on attraction techniques for ESD to facilitate an adoption of ESD in the United States. And also I developed some simplified NBI classification system. And then I did some experiment on how to do some education on the optical diagnosis to the US physicians. And then I also developed some endoscopy simulators for the ESD and also the endoscopic suturing. And then also I helped Dr. Marvin Ryu with his research on the magnetic anastomosis devices. But in addition to this research, in 2013, I started the ESD hands-on course at the Brigham and Women's Hospital with the funding from the Olympus educational grant. I think I did over 15 courses in total, and then I taught ESD to over 50 US physicians at that time. And then during the same year, there's a big changes around the ESD in the United States. So in 2013, ASGE held its first ESD hands-on course at the IT&T Center in Chicago. And then the next year, the Olympus started their ESD masterclass. I was involved in these early stage ESD courses as the faculty member. So as you know, I knew that my sabbatical will end at the end of the July for 2014. But I became increasingly interested in extending my stay to see how ESD gets adopted in the United States. And then at the same time, actually Dr. Thompson and then the division of the gastroenterology at the Brigham and Women's Hospital were seeking to establish the ESD program at that time. So this was because nobody in the New England was performing ESD. So they strongly thought that the ESD program should be developed at that time. So they really supported me in earning some visa in the license. So that's how I started the ESD program at the Brigham and Women's Hospital. So I really, I'm very grateful to Dr. Thompson and the division for supporting me to obtain visa and a license at that time. So I think all of these events reminded me of what my mentor, Dr. Kawamura, so he was my surgical mentor, told me during my surgery fellowship. So it was to challenge myself in different circumstances and then see my skills from different perspectives, like in Boston. And then if I return to Japan at the time, I would just be one of the ESD practitioners back in Tokyo. But in the United States, my ESD skills were considered uniquely special and much more appreciated. So furthermore, if I could help support the training and adoption of ESD in the United States, it would be more precious experience for me and be much more impactful for the patient who would benefit from the ESD all over the country. So this was a unique opportunity that wouldn't have existed if I had gone back to Japan.
Yeah, very interesting. Actually, that's partially what makes you a pioneer is that you actually kind of established a new pathway, a new paradigm in terms of bringing ESD and bringing other novel technologies over and introducing them to the United States. So, that's part of what makes you very unique. Let's talk a little bit about ESD, actually. Let's kind of shift gears a little bit. So tell me about the history of ESD. Kind of, it's like I realize that this will kind of be an abbreviated version of the history of ESD, but tell me a little bit about, who was considered like the four emperors of ESD in Japan. What were the roles in establishing technique? Tell me a little bit about this.
Yeah, sure. So basically the so-called like four emperors of ESD.
Mm-hmm.
So their names are Dr. Hiroyuki Ono and Dr. Tsuneo Oyama and Dr. Naohisa Yahagi and also Dr. Hironori Yamamoto. So these are the four pioneers of ESD who developed this technique. So, but all of these emperors always talk about their predecessor. His name is Dr. Masaki Hirao. He spent 2 years from 1973. Actually, this was like when I was born at the National Cancer Center in Tokyo. And then he saw a lot of early gastric cancers. So they were sent to surgery because at that time, nobody could remove those early gastric cancers endoscopically. So I think it was 10 years after this like a visit, in 1983, he developed the endoscopic resection technique called HSE. So this was basically the beginning of the technique, pre-cutting EMR. So basically, he used the injection of the hypertonic saline with the epinephrine, and then he used the needle knife to make a full circumferential mucosal incision. And then he used the snare to remove the early gastric cancers. So this was actually the first time when the ESD, the needle knife was used for the EMR. So it was 15 years before ESD was developed, but nobody else at that time was able to perform this procedure because of the risk of the perforation and the bleeding. And then I think it was in 1998, Dr. Ono from National Cancer Center started to develop a new needle knife. So he put the ceramic ball at the tip of the needle knife with his colleague, Dr. Koichi Hosokawa. And then he called it as an insulated tip ESD knife, IT knife. So it was in 1998. And then in 2001, Dr. Oyama developed the hook-shaped knife, and he named it as a hook knife with the Olympus. And then in 2002, Dr. Yahagi, he used to use a very small, thin tip of the thin snare to perform ESD, but he subsequently developed the knife called flex knife with Olympus. And then afterwards, he enhanced the knife to make it as a dual knife with Olympus. And then in the same year, Dr. Yamamoto used the hyaluronic acid for the first time to facilitate the ESD. And then subsequently, he developed the ST hood, which is like a taper tip ESD hood with a Fujifilm. And then finally, he developed the pocket creation method to facilitate the ESD. So basically, we do not know who actually did the first ESD case. And then this is like disputed because part of the issue is that this technique was also called as different names, like ITEMR, pre-cut, like a cutting EMR, or exfoliating EMR. So we don't know which pioneer did the first actual ESD case. But and finally, in 2003, this technique was named as ESD, at their consensus meeting in Japan.
I see. So, these guys all had their own technique and their own devices. Which strategy did you train with? Or did you train with all four? Or did you train in a different manner? And how did this influence your future growth and your perceptions of ESD when you came to the US?
Yeah, sure. So I actually did not learn this ESD technique from any of these four pioneers of ESD. So the part of the reason is that they were all gastroenterologists, and I was a surgeon at that time. So I went to GK University, and then the GK was not associated with any of these four pioneers of ESD and who developed the ESD knives. And then the good thing is that we are actually able to freely choose any of the clinically available ESD knives. So basically, this allowed us to choose any type of best knife for the particular situation rather than being influenced by our mentors. So to me, that was the best part of the having learned the ESD at GK University. So this kind of neutral, open-minded approach to ESD is ultimately the same style that I have tried to teach ESD in the United States. So interestingly, when American doctors went to Japan for ESD training, they typically can visit one or two institutions where they can see just one knife used during ESD. But I was in a unique situation because of my background at the GK University. I was able to choose any type of the ESD knives, and then I had a unusual knowledge of which knife was most useful for which circumstances. So along with its pros and cons.
So not only unusual in the U.S., that actually kind of made you kind of unusual in Japan too, actually.
Sure.
Now, when you first came to the U.S. and joined Brigham and Women's Hospital, what was pulpectomy like in the New England and Boston area and more broadly in the U.S.?
Sure. So when I came to the United States, as you know, nobody was still doing ESD in New England area at the time. So for difficult polyps, the only option was the piecemeal EMR. And then I saw a lot of recurrence after the EMR. So sometimes patients get lost to the surveillance for a few years. And then it resulted in large recurrent tumor with the severe scarring from the piecemeal pulpectomy. So because of that, many patients were at that time sent to surgery after the multiple failed EMR attempts. Unfortunately, this is still what we see in the United States.
Very good. And having practiced ESD both in Japan and in the U.S., what are the differences in the population that you've noticed between Japan and the U.S. with regards to colon polyps?
So that's a very good question. I think, for example, if you look at the data from some study from the United States and from Japan, I feel like the reported size of the target lesion from the United States is much bigger than in the United States than in Japan. So it's probably 4 to 5 centimeter in the United States versus 2 to 3 centimeter in the median size in Japan. I think probably the possible difference is because of the demographics. But I think one of the reason is that ESD has been universally adapted in Japan. So Japanese endoscopists are very comfortable performing ESD even for little smaller lesions, to the point where they tend not to do EMR anymore for the medium-sized lesions. But in the United States, I think we still have some selective approach to ESD. So we tend to treat bigger lesions, which is more complex. And then we should avoid the surgery by doing those ESD for those complex lesions. So as I said, the current issue in the United States is that we still receive the EFC referrals after multiple EMR attempts and then tattooing directly into the lesion. So this is actually very similar to the clinical practice in Japan, like 15 to 20 years ago, before EST was widely adapted. So at that time, similar to the United States, the patients in Japan would be referred to colorectal surgery after multiple failed EMR attempts, actually. And then we also didn't know that the prior EMR attempts would make the EST very difficult, because at that time, the most gastroenterologists in Japan didn't do EST at that time. And then, but after the EST became more prevalent, the Japanese Endoscopy Society, the JGES, launched the very aggressive education campaign. And most gastroenterologists were taught not to tattoo or attempt EMR if they are not sure if they can complete the resection, because the EST would make the EST very difficult. So I think the better education at this point is the most important thing that we should be providing to the gastroenterologists in the United States.
It's so interesting that you mentioned this, and actually this, I'd like to change gears a little bit and talk about innovation in that sense. So, it's very interesting when you look at the history of endoscopy. Actually, the first snare polypectomy was actually performed in the U.S. It was performed by a Japanese surgeon, but it was still performed in the U.S. But then, over the years, Japan really took the lead in terms of advancing the art and the science of endoscopic resection and endoscopic technology. From your standpoint, having been on both sides now, what are the key advantages of the Japanese environment that allows for this high level of innovation?
Yeah, sure. So it's a very important point, I think. So when I came to the United States, I realized a very big difference between the medical or like advanced endoscopy, like a fundamental infrastructure in Japan and the United States. I think it's very different because in the United States, the advanced endoscopists, so they are supposed to do like all advanced endoscopy procedures like EOS, ERCP, like POM, ESD, endoscopy, like bariatrics, and also the endohepatology recently. So, but in Japan, advanced endoscopy is divided into two separate fields. So one with the like EOS and ERCP, like pancreaticobiliary endoscopists, who perform just the EOS and ERCP. And then there's another advanced endoscopists who only perform endoscopic resection. So they are very good at the EMR and ESD and optical diagnosis. So if you need to do multiple procedures at the same time, it's very hard to concentrate on the innovation on the technology. But because in Japan, we had like two separate divisions in advanced endoscopy, I think it really contributed to develop a new procedure to to remove very complex lesions. So basically, some group of endoscopists in Japan. So we actually studied with the polyp resection with a snare polypectomy, and then we started removing larger and larger lesions. So for example, like Dr. Masahiro Tada, so he developed the strip biopsy technique in 1984. And then Dr. Haruhiro Inoue, he actually recently developed the POEM, but he also developed the CAP-assisted EMR in 1992. So Japanese endoscopists at that time visited like pathologist office frequently to check the specimens under the microscope to confirm their optical diagnosis. And then they also check the resection margins. So I think this level of the meticulousness is how optical diagnosis systems and then EMR and also the ESD were able to be developed in Japan. And also, I think the other aspect is that industry support was also very important. So as you know, the Olympus and also the Fujifilm, so they are Japanese companies, and then they are very close to us at that time. And then they were very eager to work with us, and then they wanted to hear from us regarding the any type of unmet clinical needs. So that is how the ESD knives were developed in Japan, and it was all collaborative work between endoscopists and also the industry.
Very interesting. You know, in hindsight now, in 2024, looking back, it's just so easy to assume that since ESD was invented in Japan, that basically just showed up and Japanese endoscopy just instantaneously adopted ESD. But now we know that's, you know, there was a significant amount of history, innovation, and investment into the technique to really make it mainstream. How long did it take for ESD to become mainstream in Japan?
Yeah, that's a very good question. Actually, it's not that easy for in Japan, ESD was adapted finally. Because when the first ESD was performed in Japan in 1998 to 2000, there's a big safety issue. So because of the technology at that time, we didn't have any like water pumps. There's no like hemostatic forceps or any like carbon dioxide like insufflators. So also the endoscopes had only just poor resolution. So it's not like that they are currently available. And also the electrosurgical generators. So they were nothing like there today. And then if there's a like severe bleeding occurred during ESD, there's no way to stop the bleeding except for like using clips and sometimes avoiding the procedure.
Wow.
And then like large perforation occurred very frequently at that time, and many patients were sent to the OR because of those perforations. For the first few years, those are the circumstances when ESD was developed. So that's why for the first few years, there's not so many people performing ESD because of the concerns for the safety issue. It was a very long journey, and then it was not until 2012. Actually, it was 14 years after the first ESD was reported when the Japanese government health insurance finally approved the colorectal ESD. But the most important part is that we cannot really compare the U.S. experience today against the Japanese experience, which happened like 25 years ago, because the technology is so much better now from the safety standpoint. So we have like CO2 insufflations, hemostatic forceps, and then advanced and electrosurgical generators, as you know. And then the biggest difference in the United States is that we have the endoscopic suturing device. So in Japan, they still do not have the suturing devices. But so even if there's a like perforation, we have this kind of like safety net to avoid the emergent surgery. So the situation is completely different at this point. So because the ESD is safer now than when it was adapted in Japan in early 2000. So because of this situation, I'm hoping that the colorectal ESD will be adapted much faster in the United States than the 14 years it took in Japan.
Right, right. And actually, you know, you're actually alluding to something which I'll mention now, and that's, you know, when you came to the U.S., you were not the first person in the U.S. to perform ESD. And there's actually multiple ESD masters who had been performing this procedure before you came to the U.S. But, you know, in your unique journey in coming from Japan to the U.S. and then combined with your passion and education in ESD, that seems to have had like a very instrumental impact in making ESD a part of mainstream endoscopy. You know, it's a concept that we call critical mass. So it's like your presence in the U.S. kind of caused ESD to hit like a critical mass in the U.S. When you look back on it now, and actually as you kind of gaze into the future, what do you believe is driving this increasing popularity of ESD?
Oh, thank you. So that's very kind of you, and I cannot give this credit to myself, but I think my one impact I had was on the education for the training on ESD was that I served as the bridge between Japan and the United States. So I knew how ESD was developed, and then how it could be successfully taught to the young faculty and young fellows. So I think when new and very complex procedures are brought to a new country, there can be some kind of like misunderstanding and misinterpretations of the how to apply these procedures. So what I was trying to do was to ESD to the US physicians how to perform ESD in the same way ESD was developed and performed in Japan. So I wanted to teach the basic principle of ESD to the US physicians in an appropriate way and try to make sure people do not learn ESD in the wrong fashion.
I see. So, interesting point you bring up because there are still ongoing challenges in the adoption of ESD in the US. What do you feel are the roadblocks in ESD that still need to be overcome in the US?
Sure. I think there are a few issues that we need to solve to facilitate the adoption of ESD in the United States. I think one of the major issues is that the structures of our advanced fellowship, endoscopy fellowship training program. So we have this 1 year advanced endoscopy fellowship, but this is too short because there are a lot of like emerging procedures, endoscopy procedures. So it's very hard to teach like include the ESD in this 1 year fellowship program. But I think some of the key institutions in the United States have already started like extending the fellowship for another like 6 months to 1 year. So that one option is to overcome this training issue. So there's also an ongoing safety issue. So especially when they finish their endoscopy training, and then when they start their own ESD program, we need to have some kind of like proctors to teach those endoscopists to launch their program safely. So I think there are more advanced endoscopists who can teach ESD to those endoscopists. So I think the proctorship would facilitate the more adoption of ESD. Also, because ESD tends to take longer time than other procedures, I think the ergonomics is also
Good point.
becoming an issue recently. So I generally follow the published guideline for ergonomics, but fortunately, I've never been injured from the endoscopy itself. But I recommend reading some article like a guidelines recently published by ASGE. I think the last major roadblocks are the health insurance and also the coding, but that will come with the time and likely soon.
Very good. And then, there are still some experts who respectfully do not believe in ESD. There are some issues I think that causes hesitancy and causes some skepticism. Do you think these criticisms eventually will disappear, or do you think that ESD itself might eventually disappear and get replaced by something easier or something better?
Yeah, I think that's a very good question. So, as you know, this phenomenon actually almost parallels with our Japanese experience. So, for example, when the laparoscopic cholecystectomy emerged outside Japan, many surgeons skilled in open surgery for cholecystectomy were against this concept. They're arguing there was a very minimal benefit for the patients, just for the skin, like the length of the skin incisions. And also when the EUS FNA was brought to Japan from the United States, after learning from the masters like Dr. Kenneth Chan, there were a lot of people actually in Japan who were against that concept. They were arguing there's a risk for the tumor seeding in the peritoneal cavity. So basically, whenever a new or difficult procedure emerges, there is a natural tendency for the people to try to protect themselves, as there may be a subconscious fear of losing their patients because they are already proficient in their current skills. So I think that basically it is a fear that their skill set will be replaced by the new procedure. So, but I'm certain that I feel the same way when if something comes along that will replace ESD in the future. So at the same time, we need to think about the disease rather than the procedure. We need to be brave and thoughtful when we acquire new skills and adapting a new procedures that may benefit our patient. I think for the time being, ESD will not disappear. And then I expect that at this point that ESD will be fully adopted in the United States in a few years. I think a lot of people have started to perform POM, paroral endoscopic myotomy, and also like esophageal or gastric ESD. And this skill set can be readily transitioned to colorectal ESD as they continue to develop their technical ability. So I think the ESD has replaced EMR over the resection of the bigger lesions, but we also have to consider that the current version of ESD was developed like 25 years ago at this point. It was like quarter of the century.
Yeah.
So there might be emerging and disruptive technology in the future. And then when we see those technology arise, we need to embrace it and start looking at those new technologies. But at this point, I think there's probably nothing that will successfully replace ESD technique, at least for the next 5 to 10 years.
That sounds pretty good. So tell me about training in ESD. Actually, we should end on a training and mentorship note. Training in the U.S., just like education in the U.S., is very different than in Japan. What does training look like in the U.S. in 2024?
Yeah, so I think to answer this question, I need to talk about different training systems. So I think for the attending level physicians, currently there are a lot of good, many training opportunities for ESD with a lot of ESD courses. And then we have also the preceptorships and the proctorships. So it's a completely different environment from like 10 years ago when I came to the United States. So at that time, most physicians who were interested in ESD had to visit Japan or Korea for a few weeks or a few months to watch cases. But right now, there are at least like 15 to 20 ESD experts in the United States who can teach ESD for the various formal courses around the country. But for the ESD training for the advanced fellows, that has a lot of room for improvement.
Yeah.
And also we need to do something about this to improve this situation. So one option, as I said, is to extend the advanced endoscopy fellowship to incorporate this teaching ESD and other like third space procedures like POM. And then the second option, it might take a little longer time, but it would be to develop a separate fellowship like in Japan for like EUS and ERCP fellowship, and then tissue resection in the third space endoscopy fellowship. So I think some of the fellows are not always interested in like a pancreatic biliary, and they're only interested in ESD and third space. So I think in the future, we can consider separating these two aspects of the training in the advanced endoscopy.
Yeah, very good. It's actually quite fun to have known you over the years and kind of watched you change as well. There are differences actually in the way that ESD is taught, but there are also differences in the way that ESD is performed now from what we've noticed in Asia and the US. So, you've been here for a while now. Do you still consider yourself a Japanese ESD expert, or now do you regard yourself as the American ESD expert?
That's an interesting question.
You're going to commit on this one.
So I think when I met you, I think I was still like 5 years into the practice in the United States. Since then, it has like almost like 5 years since you started your ESD program. So since then, actually my strategies in ESD have changed over these like 5 years. So when I first came to the United States, actually for the first 5 years until I saw you, I practiced ESD in a very Japanese way. So basically with a cap, and then I used no tractions, used a lot of like gravity. So I repositioned the patients a lot, and then I didn't cross the ESD defect to like prevent any bleeding or delayed perforation. But I did that because I strongly at that time felt that since ESD was developed in Japan, I should perform this ESD in the traditional Japanese way. It was originally taught to me. And also that was a way I successfully passed on to you as a ESD technique. But that has since changed as a result of becoming more American endoscopists. And then as a result of the collaboration with the American endoscopy companies, and then we developed a more like a new ESD knives, suturing devices, and traction devices, and then hemostatic agents. So it took a while for me to change my mindset. But I feel like the ESD needs to be modified to fit the realities of practicing ESD in the United States. So because we need to perform ESD safely as an outpatient procedure. And then I have recently started using more traction devices and or more suturing devices to close the defect to perform ESD more safely. So in that sense, I think I have become more of an American ESD expert.
You can't go back to Japan anymore.
Oh, yeah, so it's really changed my
Yeah.
mindset.
It's fun to see how, it's changed you in many ways. Not only have you changed the field and you've changed the landscape of ESD in the US, the American ESD landscape has changed you as well. It works both ways. And just kind of talk a little bit about you were kind of talking about what happened after you met me. I don't know, is that traumatic to you? But the role of mentorship, it really it permeates throughout this interview, and actually, honestly, the role of mentorship permeates throughout the entire IGIE historical consideration series that we've done for the last couple of years now. And of course, this is a somewhat biased question because you've had a huge impact on my career as my mentor. But tell me about mentorship. How did you become such a good mentor?
Thank you, Phil. Thank you for saying like that. So, yeah, I think to discuss the mentorship, I think we need to discuss our relationship as the mentor and the mentee together. So, as you know, you were my first mentee in the United States, whom I trained ESD during this fourth year of advanced endoscopy fellowship. As you know, ESD typically in Japan, it takes like 3 to 4 years at least for one fellows to become competent in this procedure. But I think I had also shared with you my worry at that time whether I would be able to train you within the very limited 1 year advanced endoscopy fellowship because I didn't know what your baseline endoscopy skills would be coming into the year. And then in addition to that, there was some kind of like anxiety of whether I would be able to create a good relationship with the fellow since I didn't do any type of the fellowship training in the United States. So I didn't know how the mentorship worked at that time. But fortunately, it didn't take too long for me to realize that you are very excellent endoscopist with the deep understanding of your technical limitations, and then that you are also very humble in your skill. So that made this ESD training very successful. So also I have to talk about the difference between the Japan and in the United States in terms of the mentorship because I didn't know how mentorship worked in the United States when I first met you. And then that was the reason why I was a little worried about whether I would be able to develop a good mentorship relationship with you. So in Japan, the difference is that the mentee would typically continue to work in the same group or same division with his mentor throughout their career, including when they move on to the junior and then to the senior faculty. So, but in the United States, I realized that most mentees start their careers at the different institutions and often in other states. But so that's the reason why I felt sad when I realized that you wouldn't be able to work with me when you start your EST program in Boston. But at the same time, I thought that for the EST adoption in the United States, this mentorship structure in the United States would work because you will bring your new skill set to another place, and then you will start your own ESD program as you have done very successfully in Houston. And then you will make your ESD available to your area. And then that would also facilitate the faster adoption of ESD throughout the United States. So I think there are some differences between Japan and the United States, but the mentorship is a lifelong relationship with your mentees. So it's like a family. So even if we are far apart geographically, it is the relationship that keeps us together while making the field better. So to be a good mentor, I treat my mentees like family. So after all, we worked in the same specialty for a long time, and so we continue working together towards a common purpose.
Thank you, and actually, it means a lot to me. And actually, just it feels just like yesterday that I was still training with you, and those all the things that you taught me, I will carry with me for the rest of my career, and hope to pass on as well to future generations that I get the opportunity to mentor, hopefully in the same way that you've nurtured me over the years. Despite your impact in the field, actually, you're still pretty young. You definitely look really young. And and so arguably you have much of your career still ahead of you. What are your plans and aspirations for the sort of next chapter in your career?
Yeah, thank you for the great question. So I think my future career would be to, so I think because we are seeing a widespread adoption of ESD currently in the United States, I think my near-term goal is to make the Brigham and Women's Hospital as like international center of excellence in the endoscopic tissue resection. So this would be like accomplished not just by training domestic fellows, but also by training like international fellows from like overseas. So for example, last year I had a fellow from Turkey, and then he completed the ESD fellowship, and then he is becoming one of the few ESD practitioner in Turkey, and he has studied ESD and PON program in his country. And then starting this July, we will be hosting a new fellow from Saudi Arabia. He'll be staying with me 2 years for the ESD training. And then he's expected to bring his ESD skill to his country. So there are now, I think, increased number of ESD experts in the United States. So there's an opportunity for the US to become the global leader of the endoscopic resection. and then we can train the endoscopists from across the world. And also my long-term vision is to expect and develop a new technology in this endoscopic interluminal tissue resection technique. So I think that technology would potentially replace the EST technique. As you know, EST was developed like over 20 years ago, and then there might be a new disruptive technology that will replace this current technique. So I think this may come with the form of the robotic endoscopy. I think there are a lot of companies trying to develop the intraluminal robotic system. And then currently we are working actively with one of the robotic endoscopy company to develop the new technology and then potentially launch EST, robotic EST program. So I think at this point, many physicians are still skeptical about like if the robotic endoscopy will facilitate the adoption of EST. But I think one day we will be able to adopt this robotic technology in our practice without a delay.
Very good. To wrap things up, you've been successful both in Japan and the United States. You've been a role model to myself, to Japanese endoscopists, to American endoscopists. You're really a shining example of someone who came from a faraway land and found success in the United States. What advice do you have for future generations who want to become successful like yourself?
Thank you. Yeah, so I think I have a few advices reflecting my history. And then I think first of all, especially I want to tell this to like young endoscopists, if you are interested in, and if there's a good opportunity, do not hesitate to move to another place. It's a little difficult changing your life from very stable, happy life to a new life. It's very, very difficult, but the great thing is that you'll be able to evaluate your skills from different perspectives. And then this insight will further improve your skills. So if you do not change anything, you cannot get better. So if you are wondering if you want to go, I would recommend just going outside your country and to be able to challenge yourself. So secondly, you need to always be open to new ideas from your like colleagues or younger generations. You have to look at your like innovative technologies. I think if there is a chance, do not hesitate to learn new techniques. As a result, you will not giving up the old skills, but rather you'll be able to build your skills further based on your previous endoscopy skills. Finally, in any part of the medicine, like endoscopy or other fields, you have to understand your technical limitations before you start your training. So this is the beginning of your training. So if you're, for example, if you are overconfident, you will not be able to learn anything from your mentors. So I think the humility and also the self-awareness, so these are very important points for your training. And if you understand your limitations, you will stand to gain so much more from your training.
Very good.
These are the three advices.
Very good. It's such good advice, and I really hope people will listen to this interview and really kind of gain. There's so much to gain from your insights and from your wisdom that you've accumulated over the years, and from really the outstanding advice and mentorship that you've given. People have just so much to learn. So thank you again so much for being a part of this, for your mentorship, and for providing this interview. I really look forward to seeing this published in its final form. Thank you again so much.
Thank you very much, Phil. Thank you for your time.
Very good.
Thank you for having me.
So, I have a
Uh,
couple of surprise questions for you.
okay.
You did not know this was coming. Okay.
No. It's still
Question number
recording?
question number 1.
Yep.
Yes, of course it's still recording.
Sure.
Who's your favorite band?
Ooh. Band. Rock band?
Whatever you like, Western or Japanese.
Oh, I really like the alternative rock. So I like the Nirvana, Foo Fighters,
Oh, okay.
Soundgarden,
Oh, very nice, very nice, very nice.
Audioslave. Yeah,
Oh, very
I really
nice,
like.
very nice. Very,
Yeah,
what?
so
Very.
usually like endoscopy nurses play those alternative rocks when I do EST recently.
You're definitely the American endoscopist.
Yeah, so I really get excited and I try not to
Were
do.
you playing American alternative rock back when you were in Japan too?
Yeah, so I
Yeah.
used to play like, yeah, the Foo Fighters, Guns N' Roses.
Oh, very
Yeah, I
nice.
did some like copy band, so
Very
I
nice,
still
very
play
nice.
guitar at home, so.
Oh, very nice. Question number 2.
Yep.
What's your favorite sushi?
Oh, so
Oh,
I remember like you took me to a very nice sushi restaurant. You talking about the kind of fish or
yeah.
yeah, so I think we went to a like Japanese restaurant together
We
in
did.
Houston. Yeah, and then
That
I
bill was
like
astronomical.
it's really um hard to find very like authentic Japanese restaurant, but actually that's the probably the best sushi that I ever had in the States.
Oh, very nice.
And then I remember I ate the kohara, which is a little like a little like fishy taste, I think, but I really like the taste of kohara. And then they serve the like probably the best kohara in Houston. So I'm really looking forward to go back to that restaurant with you
Yeah, I still remember the look
sometime.
on your face. You were like, "Oh my gosh, I have not had this since I was in Japan."
Yeah, so yeah, I think Houston is closer to me than Tokyo, so I would just rather go back to
We
Houston.
welcome to come anytime. I remember there was one time that you brought your daughter here for an archery tournament, so you're
Yeah,
welcome to travel
right.
here anytime. Question 3. Of course you're
Yep.
Japanese. What's your favorite anime?
Ooh, anime.
Ooh.
I think, yeah, I feel like I watched the Studio Ghibli
Oh.
movies, like the Princess Mononoke,
Oh, okay.
and then like a Spirited Away. So those are like very nice, very like heartwarming
From
anime.
Miyazaki.
Miyazaki, yeah, Hayao
Yeah.
Miyazaki.
Oh,
And
very good.
then I recently watched the new movie Huron and the Boy. It's a
Okay.
very nice. I think that got the Oscar this year.
Yeah, yeah, yeah. No, well, one of the it's a very famous Japanese animated studio.
Yeah, so I think I'm sorry that I feel very sorry that I think the Hayao's last movie was that the Huron and the Boy and the
Oh,
Hero.
I see. I
But
see.
yeah, it's kind of like a historical.
Yeah. Excellent. Final question.
Yep.
What's your favorite car?
Car.
Yes.
That's the good like want to buy or just like
What would you like to have?
I think I want to have like Lamborghini.
Oh, all
I really
right.
like the sports cars, but I
Oh,
also know that the
not GTR?
not GTR. Yeah, I
Not
like
GT.
the
You like the
like
European ones?
yeah, I
Oh,
like the like yeah. GTR is like a very like muscular kind of like
right.
car, but I like kind of like elegant, like a
Oh,
design, well
very
designed
nice.
like a Ferrari or a Lamborghini.
Oh, very nice.
I feel like Bugatti is like close to GTL. It's like powerful monster or something. But
Uh-huh.
I like Porsche, Lamborghini. But my wife will not allow me to get any of those. I will just like see it.
You can always rent one.
Yeah, that's true.
You could take a
Yeah.
weekend and rent one.
Yeah, that's good. Also, I want to go. I used to go to the circuit to drive the what do you call the like a small racing car
Oh, like
cart?
Formula One.
Oh no,
No,
the
no.
small ones, the
Small.
cart, like racing
Oh,
cart.
yeah, 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 yeah.
Yeah, so I used to go there every weekend
Oh, very
when I
nice.
was in Japan. So
Very nice, very nice. Well, thank you again for
oh
an
yeah, thank
outstanding
you.
interview. It's an absolute pleasure.
Yeah, thank you very much.
Thank you.
Thank you for your time.